Hello and welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ. Welcome to our webinar. Tonight we're talking about sex after breast cancer. Before we get started, some housekeeping. If you have any technical issues, there's a chat box at the bottom left of your screen. Just type your problem in there and someone will help you. Or there's a phone number you can call as well and a passcode to enter to get some help. If you're having sound problems, you might find it easier to dial up with your phone to listen while you watch on your computer. You'll see some instructions for how to do that there as well. You can use the chat box during the webinar to ask questions, which we'll get to later. And you can also chat to other people who are watching. Don't worry about missing out on information while you're chatting. The webinar is being recorded and we'll send you a link to that in the next few days. So, tonight we're talking about sex and intimacy after breast cancer. We have three panellists who are going to share with us. Our patient, Rose Wharepapa, an endocrinologist, that's a hormone specialist, Dr. Stella Milsom, and Edith Horvath, a sex therapist. First, we're going to hear from Rose. She was diagnosed with breast cancer at age 43. I think that was at your first mammogram, was it, Rose?
Yes.
And so she's going to talk to us about her breast cancer. And Rose, would really be grateful if you could tell us how that affected, or not, your sex life.
Lovely. Hi everyone, I'm Rose Wharepapa. I was diagnosed with extensive BCIs in my right breast for a mammogram at the age of 43. I just had a gut feeling really. I didn't have any risk factors, very healthy, exercise all the time. I'm actually a personal trainer. I don't drink, have a few wines but not excessively. I don't smoke. I've never been overweight. I've breastfed. I tick all the boxes to being a person that wouldn't get breast cancer. But I just had a feeling, and I can't put my finger on it. I just felt like I needed to have a mammogram. So I was training someone at the time who had breast cancer and said, just go and have it and put your mind at ease. So I did. My mind was not at ease. So I decided to have a bilateral mastectomy because I had quite a large risk of it recurring in the other side, and I didn't think that I wanted to go through it more than once. So I had both of them off, and then I had a reconstruction with implants. There was quite a few complications from my surgery, and I got infections, and I had a hole in my chest, and I had them up and down and up and down, and one up and one down. And this went on for quite some years. Consequently, I'm left with a fairly scarred chest, and it's a bit malformed. One's a bit higher and it's on an angle, but I could get away with clothing. I'm past the stages where I run around and skimpy anything. So I'm 10 years cancer-free now, and everything is going fine. At the time of my diagnosis, I was in a very new relationship with the man who I'm now married to. It was quite a highly stressful time because we just moved in together like literally a week before, and we have 5 children between us. He had 3 and I have 2, and they were coming to us every single weekend, and not long after they actually moved in, and we had all 5 of them living with us. So it was very stressful. My partner stuck by me. He was 100% supportive. He never sort of made me feel less sexy. It was never an issue about having my breasts off. Whatever I wanted, he was 100% supportive. So I guess I'm lucky. And if you're in a relationship where it's supportive, then that's how it should be. So I have always believed that my breasts weren't what made me a woman. And he was always in the opinion that I was far better off without my breasts and alive than with them and not alive. So at the moment I sort of have no feeling in my chest and no nipples obviously, and I couldn't have tattooed nipples or anything because the scarring was too bad. So it's quite handy if you want to wear a white t-shirt, I say. So I don't really actually see my breasts as sexual anymore. That's just like a man's chest to me. Like I would quite easily show them to someone and not be conscious of them. I'm happy for people to sort of, other patients to be able to see what it looks like and make decisions and things. I've always had a very positive outlook about my breast cancer and the whole situation, and so I don't have any regrets about having my breasts removed. It didn't make me feel less sexy, but to be honest, I guess if I had to enter into a brand new relationship, I might feel a little bit more nervous about, showing them to someone. But they love us for who we are. I think as women, we kind of are always critics. We're our harshest critics. We want a better booty. We want to be skinnier. I work in the fitness industry, so I sort of see this sort of thing all the time, where we judge ourselves, whereas men really just want to be in a relationship with a stable woman, an emotionally stable woman, a happy person, just they want the same things out of a relationship as we do. So they're not looking at our breasts or judging us or thinking we're less sexy by how we look. If we've got big ears or whatever we might have, breasts is the same thing. We're not. I don't think that men judge us by that, though I think that as women we tend to think they do. I try not to assume sort of now about measuring my sexuality by my breasts. So there's other ways to please a woman apart from her breasts, and I can still wear nice clothing, and I'm very happy about the decision I made. So I don't assume what people think about it, and least of all my partner. So I don't try and judge how he feels about me, because I just trust in what he says about how he feels about me as being the real, how he feels. So I'm just celebrating life and the fact that I'm alive and well, and just really happy that, I made the decision I made, and I still feel sexy and happy to be alive, So yeah, I don't have any issues with ever having had my breasts off. So I think we just have to, as women, just not judge ourselves so harshly and think that that's how people judge us. So there's more to a woman than people. So I'm trying to say.
Thank you, Rose. Thank you so much for sharing that. We really, really appreciate that. We're going to hear now from Dr. Stella Milsom. She's an endocrinologist, a hormone specialist whose work includes working in menopause and subfertility. And she's treated many women who've been through breast cancer. Stella, tell us about some of the physical side effects of breast cancer treatments that can impact on sex life, and what can be done about it.
Well, good evening, everyone. It's a privilege to be here. This is sort of the medical, endocrine, and I guess pseudo-gynecological input. Now, as health professionals, if we're going to manage a condition, if we're going to find some strategies for treatment, then it does help to be able to characterise it, because then different groups can be working on management and results can be meta-analysed. So it's been very helpful that there has been finally some classifications around sexual function, and particularly what we call sexual dysfunction. And interestingly, they actually come from the American Psychiatric Association, but you'll bear with me on that. And it's defined, if you like, in three broad categories. So where women have lack of desire, or lack of sexual interest or arousal, where women are having difficulty in orgasm, so that's category number 2, and category number 3, which is probably what we see most of, is where there's pain or discomfort in the genital or pelvic region, which just might be when someone's going about their daily activities, or it might be during sexual intimacy, intercourse, or it might be, a lot of the time. And obviously, if one's had breast cancer or treatment for the breast cancer, that might impact on some of those areas of sexual functioning. Now, I think just in terms of prevalence, it's actually common for women to have sexual dysfunction. And I think that's really important to understand, that at least 40% of the non-cancer population will have a degree of sexual dysfunction. And I guess as a practicing endocrinologist, and maybe because I'm a female endocrinologist, it definitely these days compared with 5 or 10 years ago, women are coming and feeling more comfortable raising some of these issues. If you look at women specifically after breast cancer and what their rates of sexual dysfunction, you can imagine these are not the easiest things to ascertain, but it seems like sexual dysfunction is even more common, and it might be anywhere between 40 and about 80%. So, and that's not really categorising whether it's minor or more major in terms of someone's general quality of life. What is a little worrying as a health professional is that women discuss it with their partners, and we've heard that very eloquently from Rose, and get support from their partners, but they don't find it easy to tell their doctors or other health professionals. So just in terms of the sexual health consultation, that's the next slide, Adele, I think that as clinicians, we need to be clear about what we should be asking about, and obviously we should be talking about frequency of sexual function or intimacy. Are there any symptoms of vaginal dryness? Are there any menopause symptoms? What is actually happening in someone's life? And of course it requires knowing whether a woman's got a partner, whether it's a same-sex or opposite-sex partner, not making assumptions that you know what's going on. And it's very clear if you ask doctors or you ask patients, if just about everyone says there's not enough time in that consultation. Usually the consultation is probably with the oncologist, with the cancer specialist. And that's because there are just so many other things to discuss in the consultation. So sexual health perhaps drops a little bit lower down, or perhaps there are reservations on a woman's part for raising these issues. Now, I wanted just to make it clear how specifically breast cancer or the treatments for breast cancer might have an impact on sexual function. Now, I think probably the really big one is psychological issues, and we're going to hear more about that after me. Just as an endocrinologist, when people come to see me, they think that their libido, their interest in sex, is all about hormones. Well, in fact, for women, it's actually it's probably a smaller part of the libido. Many other things have a part to play, whereas for men, hormones have a much bigger part. It's probably why men engage with prostitutes and women don't. It's just, for women, it's not as hormone-driven as you might imagine. So psychological issues, you can imagine, we've just heard from Rose, I mean, having to have a bilateral mastectomy, having pain and discomfort and drains in and around the breast, it's not very helpful for sexual feelings. There might be weight gain from the treatment. There might be, some women are going to be tipped straight into menopause, so the younger women who are premenopausal may have their ovaries removed, or they may have treatments that might just tip them into menopause, and the menopausal symptoms are often a lot worse than if you just gradually went into a natural menopause. So if you've got hot flushes day and night, if you can't sleep, if you're low in your mood, that sure doesn't do much to enhance the sex life. Chemotherapy particularly can have some issues. It can cause discharge. As mentioned, it might cause the ovaries to fail, and there might be estrogen deficiency. Some of the endocrine drugs that some of you might be on can alter the action of estrogen. So as well as reducing estrogen levels with drugs like what we call a GnRH analog, that's drugs like Zoladex and Goserelin. Some of the drugs that you might be on, like Arimidex, Letrozole, the aromatase inhibitors, they alter estrogen function, or tamoxifen, which blocks estrogen action. So they sure don't help in very important actions of estrogen. So estrogen is really important in the brain for mood and well-being, but it's also really important in the vagina. It lubricates the vagina, and it provides elasticity for the vagina. So if estrogen's not there or not working well, it may, not necessarily, it may have impacts. And then, of course, depression and low mood are very common for many, many reasons in this scenario, but some medications are going to have an impact. To be perfectly honest, in my opinion, the impact's not as great as perhaps one might expect. But if you do think the medication, in terms of time course, is having an effect, there are a couple of medications, Zyban being one of them, and mirtazapine, which are available in New Zealand, which may have less effect on libido and sexual function. So you could raise that with your doctor. Now, I'm sure if some of you are having these symptoms, you want to know some strategies to manage sexual dysfunction. And I think the first comment I'd make is that one does need to set perhaps some appropriate expectations. And it may not be that the lust of the teens and 20s with the first sexual experiences are going to be replicated in an older postmenopausal woman, particularly if there's some health issues. I think it's really important to individualize goals of treatment. I mean, they're just not going to be the same for each woman, and so particularly health professionals need not to make assumptions about what goals of treatment might be. Specifically, what treatments are helpful. Now, let's think about the vagina and the vaginal symptoms of discomfort, the lack of lubrication, the lack of elasticity. So there's some general things in terms of irritants to the vagina. So, be careful what you put down there. Don't spray, don't douche. If you get a chance, go commando. You don't want tight-fitting synthetic fibres. Natural fibres are better. So just be aware of some of those things. You might be feeling a bit reluctant about sexual intimacy, penetration, but in fact, the more sex you have, the more you actually lubricate the vagina and improve elasticity. So there are comments in the literature that perhaps sex might be decision-driven rather than desire-driven, if it feels appropriate to you. Now, specifically, some lubricants could also help if there's dryness and discomfort during sex. Vaginal moisturizers are not quite the same as lubricants. It's often used interchangeably when you're doing some reading, but moisturizers try and improve the moisture content, the water, and maybe the hyaluronic acid content of the vagina. And in New Zealand, Replens is a very popular moisturizer, so you'd use that every day as opposed to a lubricant, which would just be at the time of intercourse. Vitamin E might have a role, and from the medical professional point of view, many of you would be able to use ultra-low dose vaginal estrogen, except the women who are perhaps on the aromatase inhibitors, the letrozole, arimidex, we would avoid it in that setting. And so don't necessarily be put off low-dose estrogen if it's required and the other things haven't worked, but discuss it with your oncologist. Pelvic floor physiotherapy can be really, really helpful, and again, you just need someone who's expert in that area. They might even use dilators, find some trigger points, find areas of pain, and it might well be a multidisciplinary approach. Now, when you get down to reduced libido and reduced capacity orgasm, I think that's it's not in a tricky area, but it's probably less likely to be run totally by hormones. I think vaginal symptoms are more likely to be related to estrogen deficiency. So reduced libido, capacity to arousal, I think a multidisciplinary approach, and thinking of all the things that might impact on those areas, relationship, general health, other health issues, what medications you're on, what the relationship's like, what you're feeling, how you're feeling about the diagnosis and the way things have been managed in your body. I think all of those are equally or probably even more important than the hormones. And the strategies might well be a multidisciplinary approach. So just to sum up, I guess what I would say is that women have a right to a healthy sex life. Don't feel it's a sort of added extra. I think it's a given these days. But what you need to do is find a health professional or a group of people who you can relate to and you feel comfortable discussing your symptoms, and who in turn have expertise in terms of being able to help you. I think the more you inform yourself, and looking at professional websites rather than just Dr. Google, is very useful. Be open to the multidisciplinary approach, and I think be realistic about what might be expected in terms of age and other health morbidities and the relationship. But I think taken overall, a great deal can be done, and I wish you very well in this journey.
Great, thank you, Stella. That was super informative, very helpful. Don't forget to type your questions in, you folks at home, and we will get to those after our next speaker, Edith Horvath. Edith is a sex therapist and a psychologist at Active Sex Life Solutions. Edith, what is sex therapy and how can it help improve sex after breast cancer?
Thank you very much for having me. And it's wonderful to have these previous two speakers, almost like I saw my thunder a little bit, but it's a wonderful introduction to what I do, because I'm a psychologist and I work in human sexuality. It's a listening therapy, so I work with people around their issues around sexuality, intimacy, relationship in a non-judgmental way. So I work with people's ideas. I help them to develop tools and skills, how to manage their sex lives, how to manage intimate relationship issues. So the areas I work, especially in New Zealand, which is a very culturally diverse country, to educate and support people. I do therapy for individuals, couples, sometimes family groups. I provide workshops, and I work a lot with professionals, because a number of professionals do not get much education around sexuality and intimacy. So that is something which I think we need to discuss later on. So the specific reasons people come and seek my help is a lot of the things what Stella was talking about, low libido, difficulty with orgasm, but especially women with breast cancer issues, fatigue, body image issues, issues around shortness of breath, a lot of issues around how to deal with the effects of treatment, chemotherapy, radiotherapy, etc. And I work not just with the women, but with their partners, because a number of times the partners wouldn't know what to do or what not to do, and how to approach this, how to talk about this. So a number of times I work with the woman who's got the breast cancer, or the couple, or with the partner of the cancer person. So as Stella eloquently said, sexuality is a right. It is a human right, and just because somebody is going through some life-threatening illness, it doesn't mean that you shouldn't get the benefit of somebody loving you in a positive way, especially touch. The wonderful, soft, loving touch is so important and so healing for all of us. So I talk about the clinical touch, because when somebody is going to hospital or going for chemo, they get a lot of clinical touch, like blood pressure, blood samples. These are not loving, supportive touches. So we all need that aspect, which is part of our sexuality. So what is our sexuality? And most people, when I talk about sex, of course that's my job, either squirm or smile and laugh and start talking quite openly about sexuality or sex. Our interpretation and our views around sex is dependent on our family background, our religion, our culture, our education. So it is quite complex. So two persons would see the same issue quite differently dependent on their background, dependent on how they grew up and how they interpreted whatever happened in their past, both sexually and just in normal life. So what is sexuality, especially when somebody is going through breast cancer or any serious illness? It is enabling us to express ourselves. It is part of our well-being. So when we can dress the way we want to dress, we can groom ourselves, we could put some makeup on, we could experience closeness, and this is where that positive touch is so, so important, both from friends and family, but from our lover, from our partner, if we have one. We need to acknowledge the physical and psychological changes which do happen when somebody has breast cancer. And Rose talked about changes physically, being treated physically, and the pain around the chest area, which can go on for quite a while. So a number of people who come and talk to me about, yeah, I don't have the pain anymore, but I'm very sensitive in my chest area. I don't want to be touched. So how we express our sexuality and our sexual needs, intimacy needs, are very important in our relationship. So we potentially need to redefine intimacy and potentially our sex life. And again, Stella talked about this. Our expectations need to change dependent on where we are. And it's not necessarily just where we are with our cancer journey, but where we are in our life stage, where we are with our relationship, what stage it is. It is an old relationship, or it is something new, what you talked about, Rose. So the ability to express our needs are very important, to be able to communicate what we like and what we don't like. And this could change. This could change from day to day. This could change dependent on where we are with treatment. This could change just because. And we are women, so we can. So we need to appreciate our sexuality. And some of that sexuality is really basic. It's looking, it's touching, but going further into a more intimate sexual life, intercourse, etc. But all these are personal choices. All these are what we want, and be able to communicate that, and how and when we communicate that is paramount. A lot of my clients come to me and ask, when do I talk about these issues with my partner? How do I say what I want, what I don't want? I always sort of say, don't discuss it in the bedroom when you are just about to have sex. That is probably not the right place and not the right time. However, talking about these issues can be quite sensitive. These issues can be something what you want to do in private. So you want to make sure that the children are put in bed, they can't hear you, it's not in a cafe or in a pub. So you want to create some space where you feel comfortable talking about these things. You need to feel safe when you talk about these issues. So if it's a brand new relationship and you're uncertain about the other person, you probably want to gently introduce the issue around, well, I have cancer and I want this, or I don't want this, or I want to go slower about this. Sometimes our bodies communicate what we want and what we don't want. And that is sometimes when you are touched on certain part of your body responds in a negative way, freezes or gets cold. Other times it melts away because it's so beautiful. And sometimes it is a new body part where we don't expect because we never tried that. So when I talk with my clients, especially women who's got pain or sensitivity in their chest after surgery or radiation, it is really, really useful to have sessions, have little times with one's partner where in a non-sexual way explore the body where you feel nice and comfortable to be touched and how to be touched, because sometimes it can be very soft, other times it can be a little bit more dependent on, again, what you like and what you don't like. So I'd like to talk about two cases, two of my clients who had breast cancer. And the first one, she had some major body image issues after she had double mastectomy, and she came to me with the problem that her husband wanted to have sex, but she did not want to take her clothes off. She just felt that she was not ready to see even her own body, let alone her husband to see her body. So we started to work through in therapy around starting to look at her own body and started to make friends with her own body. And following that, we worked out strategies around how to make sure that she feels a little bit more comfortable to take some of her clothes off in front of her husband. So we came up with ideas around having a lovely, beautiful bra which would cover her breast, as well as have a top which would drape around her breast. So we worked through that, as well as to have candles in the bedroom. So the light was a lot dimmer. So she felt a lot more comfortable around taking her clothes off or taking part of her clothes off. So we worked through this. So week by week, we didn't push it. We let her guide the therapy and let her guide the relationship. And I believe that her husband, just by coming to therapy and working through and noticing the changes, noticing the comfort around, actually, we are working through this and we are succeeding. And after 2.5 months, 3 months, and we are succeeding. And after 2.5 months, 3 months, they enable themselves to have a very loving, intimate time, and I let them go, and they live happily ever after. So I'd like to talk about another case where my client started a relationship, started a friendship with a lovely man just before she was diagnosed with breast cancer. So they started to create a beautiful friendship, and she was diagnosed, and she needed a carer because she lived on her own. So he moved in with her as a carer to the household, and he supported her, took her to appointments, and made sure that she was taken care of as a patient. But of course, as the time went on and she finished her treatment, they needed to transition their relationship from that carer-patient relationship to a lover type of relationship, because they loved each other through the relationship. They really grew and started to deeply love each other. So it was not easy. So when she first came to me, she said, look, how do I do this? What do I do so we could become sexy partners rather than a patient and a carer? So we started to talk about how the bedroom looked. And she said, oh, it's lovely and clean and white. And so the impression I got was that it was very clinical, everything was so white or cream colored. And it turned out that he didn't even have space in the wardrobe for his clothes because all the medical stuff was there. So I said, oh, so the medical stuff needs to be there. Said, no, I'm all good now, I don't need any of that. I said, well, why don't we make some room for his things in the bedroom so he feels part of that intimate space, the bedroom, as well as maybe allow some color into the bedroom. So she loved that idea. So she created some red cushions and throws, and he was delighted because finally he felt he was part of the bedroom because his clothes were there, and he was allowed to take some of his personal belongings into the bedroom. So we followed sort of slowly from there how to enable times within their days where they were not patient and carer, but they became more lovers. And it started cooking together, touching each other very gently. He was working from home, so having a lunch date. And again, just little times where they could kiss each other or go for a walk after work. So that slowly transitioned their time together and their spaces at home so they could create that lover relationship and spaces within the house, especially in the bedroom, where they didn't feel that he had to check on her, how she was feeling, blood pressure, etc., medication. So again, I was working with her to allow her to create the environment, to create the new behaviors between the two of them, where they could change how they talk to each other, how they behave towards each other. And of course, they found their own rhythm with this. And after a while, again, I let them go and do their own way of recreating and growing their relationship together. So these are the key areas I work in. So rearranging one's environment, one's behavior, helping people and supporting them to rediscover themselves and rediscover their relationships and grow their relationship, because we don't know what tomorrow brings.
Thank you so much, Edith, and thanks to all three of you. We're now going to open up to some questions from you at home. We don't have a lot of questions at the moment, so if there's something that you really want to ask, go ahead. And you can type your questions in the box at the bottom left of your screen. We'll get through them all at this stage. We're doing well. So I'll just kick off with the ones we have got. First off, Stella, one for you. Are bioidentical hormones definitely a no-no if your cancer is hormone positive? Confident with that one?
It's a very topical issue. I think first, the quick answer is they are a no-no. They are in fact very active forms of estrogen and sometimes testosterone. And remember, testosterone is just simply converted into more estrogen, so it's an extra dose. A couple of other things. There's no such thing as bioidentical hormones. If what you mean by bioidentical is so-called natural hormones, then in fact we have around the world, including New Zealand and Australia, we have many approved forms of natural hormones that can be used in this situation, depending on an individual's medications and risk profile. So you can have prescribed natural estrogen and natural progesterone, and we know the safety data, we know the risk-benefit profile, we know any side effects, and so you would have to ask yourself, why would one be going down an alternative pathway which in fact has been developed as a marketing tool? Yeah. So a lot of the misinformation on the web. I mean, I'm very aware that Suzanne Summers has a YouTube clip which, states that it's very safe after breast cancer to use bioidentical estrogen. Well, bioidentical estrogen is just unstudied, but strong estrogen that one can't even be certain that one preparation is the same as the next. Yeah. There's some really good accurate statements about these hormones and the pros and cons from a lot of professional websites. Have a look at the Australian Menopause Society or the American Endocrine Society, which have a good statement which explains these issues quite simply.
Great, thank you. Now the next question, I think I'll get both of you to take a look at, which is, have you seen much difference in your practice between pre-cancer treatment orgasm and post-treatment? I think that's what patients are telling you is the change between before and after.
The answer is yes or no. It really depends on the age, the health, both before cancer and after cancer of the woman, as well as the relationship. Because there are some women who had very poor or no orgasm before the cancer, but afterwards they have better or more orgasm because their partner would be a lot more patient and a lot more careful with them. So it's really dependent on the individual, how it works and what sort of advice they do get, both from doctors, oncology nurses, friends, Mr. Google, because a lot of it is lubrication. A lot of it is whether they have pain and whether they get any treatment for that pain, how healthy they are, and whether they are relaxed and happy in their relationship, and the skill set and the patience of the lover, because that can be very, very important. Any stage, any age, but especially when people went through. Anything?
Look, no, I think that's an excellent answer. I mean, I think there's a couple of comments that I'd make is that sexual function, if you like it, I don't know, I think it's just a spectrum. I mean, and I think what we have to establish, and I do very carefully take a history of someone's experiences in terms of sexual function. So I think that there are women who really don't have much sexual desire and never have. And so I think there's enormous variation from that into someone who is easily and highly aroused and frequently. I think there are partner issues. I mean, there's no right or wrong how often or how often not to have intercourse. And of course, it doesn't have to be intercourse, as we've heard. I mean, intimacy is probably a better terminology, and some of that might be to do with intercourse. What I do see, just from the endocrinologist perspective, is that if women have never been very sexually active beings, they certainly don't get better when they become postmenopausal, and that could be postmenopausal just because they've got to that age, because they've had their ovaries removed, or because they've had chemotherapy. So it doesn't really matter the cause. Women, however, who've had a very good sex life and become postmenopausal, and again, regardless of cause, so not specifically after breast cancer, sometimes do quite bitterly describe a reduction in sexual functioning. And again, yes, there are differences in estrogen, but I think it's far more multifactorial than that. And often I will say to my patients, I mean, of course we'll go through the hormones and the medical side of it, but almost invariably we'll have assistance from our psychology colleagues. You know, I often tell my patients that the psychologist may well fix more sexual dysfunction than I do as the endocrinologist. And remember, I'm seeing premenopausal women who have excellent hormones. I mean, their periods are quite regular, their hormones are fantastic, and they have
quite marked sexual dysfunction. It's a very complex area.
And I said that while we're talking about psychology and so on, we do offer free counselling with psychologists and other counsellors, and so you might find if you talk to one of our nurses that you can get a referral to a psychologist who can help in that area too. Okay, next question, what is the best lubricant water-based? Not sure if that's a question, water-based, or what's the best water-based lubricant?
In New Zealand, my gynecology colleagues tend to suggest Astroglide or Silk. If you go to two good websites, so the Australian Menopause Society or Jean Hales Institute from Melbourne, and they've got an extended range, and of course I think some of those are available in Australia rather than New Zealand, but with some internet-based purchase power, I think most could be obtained. If you're talking about a moisturiser, our oncology nurses are very enthusiastic about Replene. I think a comment though is that the moisturisers can be very helpful, and as I say, they're used on a regular basis as opposed to the lubricant just for sexual experiences, but that the moisturisers in general probably don't compare with the effect of actually replacing a little bit of estrogen, because it's that estrogen missing that's affecting, as I say, not just the vaginal mucosa and the glands secreting, but also the elasticity. There are some other things in development too. I mean, in North America, they're looking at vaginal, an unusual, it's an androgen, DHEA, but of course, safety after breast cancer would definitely need to be established, and there are some oral preparations coming on track.
And I guess coming back to what you said, Stella, about the fact that actually having sex does help. The more sex you have, the better. Question here, does masturbation improve vaginal dryness?
Good, that's a really good question. I'm not aware that it's been specifically studied, but I can't see why masturbation, particularly, if you, let's be blunt here, digitally penetrate the vagina and stretch, should, I think, be a useful thing too. Yeah.
And I think if good lubricant is used, it helps, because when there's no intercourse or no way to enhance the vaginal muscles, it's absolutely. So, we do need to acknowledge the fact that if you don't use it, you lose it. Yes. And it becomes much harder later on.
And that, as I said, there's an excellent article from Jean Hales, this research institute in Melbourne that really focuses on women's health, and they have an article entitled, the female libido, and they discuss that comment that I made about decision-driven intercourse as opposed to desire. Right. That provided it's safe and it's enjoyable, then sometimes, it's actually a matter of deciding that one should go ahead and have intercourse rather than waiting for that rush of lust that may, in a longer-standing relationship, in an older patient, just not going to be, unfortunately, the same as it maybe was when someone was younger.
I mean, I have couples who come to me, and not necessarily with breast cancer, but sometimes breast cancer or prostate cancer, but couples without cancer as well. And they talk about the fact that if they plan and if they have like a date night, so they know it's going to happen, or the environment, the setup is that we're going to have an intimate time, a loving time. They talk about the fact that actually we didn't have much desire before, but we got right into it and we really enjoyed it. So if the context, if the environment, if the situation is there, it is much better, much easier to rekindle and then have either intercourse or just a beautiful sexual intimate time. So I think if we have the timing right and the decision making that we're going to do this, then the feeling will come with that.
But also if you feel confident about your sexuality and yourself. So if you think that you're pretty, and whether that's been putting on a nice dress or if it's putting on some makeup, or if it's treating yourself to have a manicure, or whatever rocks your boat and makes you feel good about yourself. If you embrace those things that make you feel good, it might be exercise at the gym, it could be anything, then you feel more womanly and more sexual. Just like when girls, why do women get dressed up when they go out? You know, they put makeup on and they groom their hair. And so my theory is always, if I feel a bit flat or if I don't feel very sexy, I try and make myself sexy. So I'll spend extra time on my hair, I'll put a nice lipstick on, or whatever the case, and a nice dress.
It's very much decision process.
Yeah, it's a real psychological thing. And it starts as soon as you wake up in the morning, the contact that you have with your partner. So if he's nice to you and friendly and touches and chats to you and he's not grumpy, then you go to work and you think, oh, so cute. And then by the end of the day, you're still loving him, and then sex is going to happen. But if he's an arsehole, for want of a better word, or you know, like he's grumpy and then all of a sudden he rolls over at night and let's go for it, love. You know, like I don't think so. So that whole building into the sex is a thing that comes about your intimacy and building that intimacy with that person on a daily basis.
When I talk to some of my couples about when they reject this idea, oh, we have to plan, we have to have a date night, whatever, I said, when you first met, I'm sure that both of you, when you said, oh, we're going to meet Friday night, for Thursday and Friday during the day, you were thinking what I'm going to wear, how I'm going to
all
that. So you were preparing, you were planning, you were doing all that. Now that you think that you've been married or been together for a long time, you know, that is artificial. Well, no, because that whole build-up is part of having anticipation and excitement and building up the excitement.
Yeah, good point, good point. Let's move on to another question. It's been 5 years since my treatment finished. I seem to have quite a large amount of vaginal dryness and itchiness. I'd like not always to have to use lubricant, etc. You mentioned vitamin E earlier. Are there foods, etc., which is good or bad for this?
Unfortunately, there's no data that there's any food supplement per se. Oral or vaginal vitamin E, though, is said to be helpful, although the quality of the data, but so it might be well worth a try. And if you're 5 years and you're not on an aromatase inhibitor, and you've perhaps explored the lubricants and the moisturizer options, you know, then a discussion about low-dose vaginal estrogen. Remember, vaginal estrogen is ultra-low dose and essentially is not absorbed into circulation. So we're not talking about systemic hormones, which, yes, we would prefer to avoid. But, look, I actually agree with the other speakers. I think that setting the scene physically in terms of ensuring good physical health and ensuring good mental well-being are probably 3/4 of the issue. And I think the comment that sometimes you just can't wait for it to happen to you, you have to take those initial baby steps to set up that scenario.
And someone's asked about feeling tired and not sexy. What about using melatonin for sleep?
Look, the whole sleep issue is very interesting, and I spoke about that at the Congress, Menopause Congress at the weekend. There's no doubt that poor sleep is part of the set of symptoms for postmenopausal women. And yes, estrogen deficiency can give some people night sweats and a feeling of heat, but there's far more to the sleep issue that comes after menopause than just night sweats. In terms of managing that, probably first line is actually cognitive behavioural therapy. And there's a useful program, I'm sure there are plenty, but one program that many of my patients engage in is called Shut Eye, appropriately, and it's sleep CBT administered by the University of Virginia. It's a completely internet-based program. So that's called Shut-Eye, as you could imagine. Then melatonin certainly has a role in sleep, but it's been very hard to know the differences between physiological and supraphysiological levels. I don't believe there's any data in women who have had a cancer or a breast cancer diagnosis to ascertain safety, but I don't suspect there are likely to be issues. Trouble with melatonin is how long do you use it for? just in terms of other ways of helping sleep, you know, again, I think there are a lot of strategies in terms of getting up at the same time, going to bed at the same time, practicing techniques such as neuro-linguistic programming, which are incorporated into this sleep program I mentioned. Relying on sleeping tablets, look, they're fine for an emergency, but they don't give you a lot of sleep and they don't give you good sleep architecture, so they're very short term. Things that women do may be disadvantageous. I mean, drinking alcohol, not only is it bad for one's risk of breast cancer recurrence, but it's bad for sleep. So I think there's often a lot of things that women are doing that they could
healthy diet and exercise, the regular exercise and healthy diet. And I know I'm coming from a gym point of view, but
absolutely right.
I know that if I've had a workout, whatever it be, it can be a walk or whatever, if I've got some fresh air and I'm eating healthy. When I eat unhealthily or when I drink alcohol or anything that keeps you awake, you don't sleep so well, your sugar levels are going up and down, you know, for whatever. So a balanced diet and exercise is really helpful towards getting a good night's sleep.
The data suggests exercise a little bit earlier in the day. Don't do all your exercise late at night and raise your body core temperature.
Yes,
that would be disadvantage.
That's a good point.
You know, you know, the Deepak Chopra advice would be, you know, exercise, get out, get sun exposure in the morning and in the afternoon, keep regular hours, don't try to catch up with naps during the day and, you know, sleeping in and going to bed earlier. That just destroys the arrangement. Yes, lots of green leafy vegetables and perhaps the lightest meal being at the end of the day.
We have a couple more questions that more sort of relationship-wise that you might be able to help with. When you've got a new partner, at what point do you say, I only have one boob?
Well, it depends on, probably not the first date. I think when you know that the relationship is worth it, when you know that you would like to take it to the next step, then maybe not say like that, but start with the fact that you had a life-threatening illness, you have cancer. And then I think that unfolds from there that, yeah, I have to have a surgery and that this is the effect, etc., etc. I think most people know when that time is. Again, probably not in the pub, not in sort of when you had a few drinks, because that will not land well, and you probably won't say it the way you would want to say it. Because that will not land well, and you probably won't say it the way you would want to say it. But start thinking about, is this person worth for my honesty? Is this person who I want to feel a little bit closer? Think about it as a friendship. You know, when would you disclose to somebody who you start to be friends with something like this? Probably not the first time you meet them. So try to sort of feel safe about it, and for the relationship, that if you think it's serious enough, then you start sort of disclosing slowly that you had a serious illness and this is what it was and the effects of that. And that might not be one conversation, it could be several.
Yeah. But I mean, most people in a relationship, they don't just climb into bed with someone straight away or get that intimate with someone straight away. You go out on dates, you talk about your family before, or you trust that person enough to get intimate with them. So I feel that just comes along at the normal time as everyone else. You know, when you start to discuss things like, you know, you've got extra toes and
what's going on now?
all those things that you wouldn't tell someone that comes along when your intimacy grows with that person. Like you said.
And also, here's something from I'm 47 and single, broke up with my fella just after diagnosis. I struggle to trust any man now. Any advice in learning to trust again?
Start with yourself. Start trusting yourself, and use those strategies that Rose was talking about. You know, make yourself beautiful for yourself. Treat yourself nicely. Feel healthy, happy, and then slowly start looking at options, looking for new friends. I think it's really hard to sort of look for that perfect person because normally they don't exist. they have most of what you want from a relationship. So really start with yourself, start trusting that you are beautiful, you're worth it, and after that, slowly open yourself up to possibilities to meet somebody.
Right, that's good advice, thank you. What can you use for hormone cream if you're HER2 positive? I mean, it's a bit of confusion about whether the type of breast cancer has an effect on what type of.
Look, I think that you would want to have a discussion with your oncologist, but again, as I mentioned, estrogen cream is local. It's almost no systemic absorption. So apart from the setting of being on letrozole or one of the letrozole-like drugs, I think most oncologists, if you required it for vaginal symptoms, would probably be in agreement. But have that discussion. No, it would be wrong for me to sort of make a comment for all other health professionals.
Can you please advise again details of the doctor from Melbourne who wrote about women's libido? Was that the gene?
Oh, sorry. Yes, I was discussing the Jean Hales, Hailes Institute. It's a very big research institute which has a lot of health professionals in different areas of medicine and health who specialise in women's health. And so a lot of good information from there and a lot of good information from the Australian Menopause Society.
So we'll get some of those links that you've mentioned. Yes. We'll go through and get those. And when we email you guys in the next few days to let you know that the webinar is available online, we'll include some of that backup information for you in that email. Finished on it. I actually had one question to you, Stella. Right at the start you said about 40% or more than 40% of people have some kind of sexual dysfunction. How do you say whether it's a function or a dysfunction when you've got that many people? What's normal?
Well, I guess that now that we've got an ability to characterise what areas of sexual function we think might be problematic, yes, we can say it's a very common problem.
Yeah, right.
And I think, again, if you've done this survey 20 years ago, 10 years ago, and in 2017, those figures are different. I think, too, compounding the problem is the media who have a view of sexuality, which all I can say is as a practicing endocrinologist, and I do hear a fair bit about sexuality, both in younger and older females, and of course males. I look after men as well. What the media have to say, basically that everybody's at it like rabbits, doesn't seem to be a much relationship to real life.
Yeah, so let's not feel the pressure.
Exactly, good.
And just one more quick question, I think. How soon after treatment is finished can you start on an estrogen cream? I don't see, and provided you're not on these adjunctive treatments where it would be relatively contraindicated, I don't see any reason for delay. So you weren't on hormone therapy and so on. But again,
it's likely that perhaps the symptoms are often a little bit delayed. I mean, if you think about women with a natural menopause, the symptoms, the vaginal symptoms, which now have a trendy new name called GSM, or genitourinary syndrome of the menopause, rather than vaginal atrophy, thought to be a bit pejorative, those symptoms do come later. So the sweats, the moodiness, the irritability, the joint aches and pains, that all comes sooner, and some, often, in fact, some years down the track, there are more prominent vaginal symptoms. But conversely, they do tend to persist.
Okay, look, our time is up, I see. So thank you very much for joining us tonight, all you at home, and thank you again to Rose and Stella and Edith. You've all been absolutely fantastic. We hope everyone found this helpful, and we'd appreciate if you could take time to give us your feedback as you exit the webinar. Could we get the slides back up on the screen here? Because I just wanted to give you a heads up about an event we have coming up on Sunday, November the 12th. It's a free patient information day. Let me find this. 9:30 till 3 at AUT. There's a bunch of breast cancer researchers from around the world coming to New Zealand mostly to talk to each other, but we've managed to grab a few of them and get them to talk to patients and their supporters and so on as well. So it's a free day. You can register online at the addresses given on the screen there. We're talking about things like genetic testing, vitamin C, personalised medicine, self-hypnosis, and various other cool things. So come along to that. We'd love to see you. If you have any questions about this webinar or the things that we've discussed tonight, our breast nurse Vivian is available until about 9 o'clock tonight. You've got her number on your screen there and also her email address, or you can catch her on our 0800 BC nurse line tomorrow. As I mentioned before, we have referrals to free counselling and also funded physical rehabilitation programs, which might be an issue for some of you. And you can connect into MyBC, which is our breast cancer community, online community. Okay, that's it for tonight. Thanks very much for joining us, and we'll see you next time. Bye.
Bye.